So good evening, everyone. And this is the first session probably on the history and evolution of ventilation. The talk will be taken by Dr. Vitraj Shah, who's a senior consultant critical care medicine from Surat, and he at the Velocity Hospital, Surat. And he'll speak for about half an hour on this, and then we have a talk on introduction to mechanical ventilation. I'll be there to kind of moderate, discuss, carry on the discussion. You can, if you have any questions, you can put it in the chat box, and we will address it at the end of the talk, and we'll have a discussion at the end of the talk. So, Vitraj, you can go ahead.
Thank you, sir. Thank you for starting an introduction. So, without wasting further time, let us start with the wonderful history and evolution of ventilation and devices. So, it's very surprisingly, when I was given talk, I was not much aware about all this history of ventilator, but surprisingly, it is very long history. And these two articles I liked very much, so I just put the title in first slide. One recently published in the time.com by Alexandro de la Garga on 7th April 2020. Title is very catchy, that is surprisingly long history of ventilator, the machine you never want to need. So it's very catchy title. And second article was history of mechanical ventilation from Vesalius to ventilator induced lung injury by Slusky. So let us start with the history of intubation first. So as early as in the 5th century before Christ, Hippocrates has described a technique for prevention of expiration. So Hippocrates stated that one should introduce cannula into the trachea along with the jawbone so that air can be drawn into the lungs. So that was first technical description of intubation in 5th century BC. So many years back, Hippocrates had already started the concept of intubation. And in 1880, it took so many years to technically get endotracheal tube and use in practical scenario. In 1880, ET tube endotracheal route was the use first time for cannulation of trachea, and before that tracheostomy was being used instead of endotracheal route. So history of tracheostomy, it is also quite ancient. Rig Veda, that sacred book of Hinduism, written in between 1000 to 2000 BC, and Egyptian literature, Abyss Papyrus in 1550 BC, both mention cutting into the neck to access the windpipe, which is the first documentation of tracheostomy. So we can see intubation and tracheostomy both have quite old history from our ancient literature, Egyptian and Hindu both. So now history of mechanical ventilation. So it started with Paracelsus. First form of mechanical ventilator, it started in 15th to 16th century. First form of mechanical ventilator can be credited to Paracelsus, who in 1530 used fire bellows fitted with a tube to pump air in patient's mouth. Thereafter, in 1653, Andreas Vesalius recognized that artificial respiration could be administered by tracheostomizing a dog. So in his classic De Humani Corporis Fabricia, Vesalius stated that, but that life may be restored to the animal, an opening must be attempted in the trunk of trachea in which a tube of reed or cane should be put. You will then blow into this so that lung may rise again and animal take in the air. Also as I do this and take care of the lung is inflated in interval, motion of heart and artery does not stop. So this is the exact sentence in his classic which is mentioned. So from this, there are many controversy in history as well, that Andrew Vesalius has invented that, or he has that observed and mentioned in the book, and someone else has invented. So we don't know that detail, but what we could found in all articles, I could found that this is the statement by Vesalius of ventilation. So let us start with initial history. So before even Paracelsus and Vesalius, it was Galen who has introduced the concept of breathing, which is required for circulation. So Galen was Greek physician in 2nd century AD. He had done many discoveries on anatomy and role of anatomy in the understanding of disease. And he stated that respiration required for circulation. Without respiration, circulation will not occur. And thereafter, after almost 1500 years, it took so many years to get concept of mechanical ventilation and further development of ventilators. So that era was called Dark Ages because there was no new invention between 2nd century AD and 15th century. And after 15th to 16th century, there have been so many new developments, which we will be going in subsequent slides. So further journey after Vesalius was between 17th to 18th century, quite interesting. So almost 100 years later, Robert Hooke has duplicated Vesalius experiment on thoracotomized dog. And Hooke has made interesting observation of physiology of ventilation, that it was not merely the regular movement of thorax and ventilation which prevents asphyxia, but maintenance of phasic airflow, inspiratory and expiratory airflow into the lungs, which prevents the asphyxia and maintains circulation and oxygenation. Thereafter, there is first instance of human resuscitation by mouth-to-mouth breathing, which was described by John Fothergill in England in 1744. Then in 1774, oxygen was invented independently by Joseph Priestley and Wilhelm Skelly. And subsequently, Lavoisier discovered its importance in respiration. So thereafter, there has been use of bellows to resuscitate the victim of near drowning by Royal Human Society in 18th century. So Royal Human Society was constituted in 1767, but after use of bellow for resuscitation, there have been several cases of fatal pneumothorax due to vigorous attempts of resuscitation, and it led to abandonment of such technique. But thereafter, John Hunter's innovated double bellow system, one bellow for blowing the fresh air and another for drawing out the contaminated air. And it was adopted by society in 1782 and introduced a new concept of ventilation. So now history of real negative pressure ventilation, which we all remember, iron tank ventilator, started in 19th century. In Scottish physician John Dalziel in 1838 described the first tank ventilator. And after that, in 1864, body tank ventilator was developed, which is the landmark of iron tank ventilator, by Alfred Jones of Kentucky. A patient was seated inside in an airtight box which enclosed his body neck downwards, and negative pressure was generated within the apparatus, produced the inspiration, and expiration was aided by cyclical generation of positive pressure at the end of each inspiratory breath. And Alfred Jones took a patent to his device, body tank ventilator, and he claimed that it could cure not only paralysis, neuralgia, asthma, and bronchitis, but it also cures rheumatism, dyspepsia, seminal weakness, and deafness. So just in brief, schematic representation of this negative pressure ventilation. So this is the subatmospheric negative pressure, outside it atmospheric positive pressure, and in the mouth you can see atmospheric positive pressure. So due to negative pressure inside and outside the chest and inside the cage, there is expansion of the chest and air goes in due to positive pressure from atmosphere, and removing the negative pressure allows the passive exhalation by elastic recoil. So this is the actual representation of this body tank ventilator. You can see that patient is sitting with his crossed leg, and head and neck is outside the ventilator. So we can just imagine how cumbersome the discovery of ventilator was there. Or patient on ventilator are already suffering. They cannot even sit, and this first ventilator was developed in sitting position. So there are further modifications which improved subsequently, and that many more innovations have been there. So further innovation done for asphyxiated children. So Wallace hand cracked spirophore in 1876, which was proposed to keep for resuscitation of drowning victims, in which doctor operated the spirophore by cranking the handle. Thereafter, Egon Braun has developed small wooden tank, and it needed the treating physician to vigorously suck and blow into a tube attached to the box that is enclosing the patient. So we can see if there is any epidemics and doctor need to suck and blow the air, so how can we manage the patient? But that's how ventilatory principles evolved. So they also realized that we cannot manage all these things, and then invention of respirator room and ventilator room subsequently occurred. So to overcome the problem of nursing care, Peter Lord had patented respirator room in which patient can lay with her head outside the room. But it was too expensive. So later on, to ventilate multiple patients in single chamber, James Wilson has developed a ventilator room in which multiple patients can be ventilated. Thereafter, Wilhelm Schweik's pneumatic chamber was invented, in which patient himself could lend a hand in pulling and pushing against the bellow, which will generate negative and positive pressure. Thereafter, iron lung, actual iron lung was invented and further discovery between 19th century to 1950. So in Harvard Medical School, there was a team of engineer, physiologist, and engineer was Drinker, physiologist was Shaw, and physician McCann. All these three invented apparatus for prolonged administration of artificial respiration, which was dubbed as iron lung, and it was quite similar to Alfred John's ventilator. So subject at first they use paralyzed cat, and then they use patients of poliomyelitis was laid within an airtight iron tank. Padded collar was applied to the patient neck and provided seal, and pressure within the tank was rhythmically lowered by pump or bellow. Initially with bellows, and then with further innovation, pump from vacuum cleaner. So access to the patient for nursing was limited through the consultation and monitoring. So Emerson in 1931, a variation upon this iron lung was incorporated, an apparatus with which it was possible to additionally deliver positive pressure with at the mouth, and this made nursing very easier. So now patient could be supported on positive pressure breaths alone while the tank was opened periodically for nursing and examination. So here is the picture representation of Drinker Shaw or Drinker Collins respirator. You can see head is outside and rest part is inside, and nurse is seen from this window part. And this is the modification of Emerson's iron lung. Here we can see multiple patients are in single chamber. So to overcome the economical challenge, they have developed this. And its most invention occurred in ventilation world during polio epidemic. Like in COVID, there were so many new innovation have been there. So in 19th century, polio has led us to rapid development and evolution of concepts of ventilation. And surprisingly, in 1950 also, they were transporting patient on ventilator. So this is the transport iron lung. So this was quite cumbersome, as we can see from the picture. So further modification occurred toward the end of 19th century. Similar principles like iron tank ventilator were developed by Ignaz von Hock of Austria and Rudolf Eisenmenger of Vienna and Alexander Graham Bell of USA. And it was named cuirass because of its similarity to the 15th century body armor consisted of breastplate and backplate, which were secured together to form airtight seal, and negative pressure generated by means of bellows, and during subsequent year by motor from vacuum cleaner rather than bellows. And it is definitely beneficial over iron track in term of less circulatory embarrassment, but it was not as efficacious as iron tank for ventilation. So it was also not much used, and further innovation occurred again. So this is the pictorial representation of the ventilator cuirass. So further innovation in early 20th century, advances in the field of thoracic surgery saw the design of surgical chamber by Ferdinand Soberbruch in 1904, and this chamber functioned much on the same lines as the tank ventilator, except chamber included not only patient torso, but it included surgeon himself as well. You can see the picture on the right side. So surgeon can also come inside and stand beside the patient, but head was outside this chamber. So Brower reversed the Sorbeck principle of ventilation by enclosing only the patient's head within a much smaller chamber, which provided a positive pressure. So he reversed it. Rather than enclosing entire body, he enclosed just patient head and keep out as part rest all parts of the body outside the tent. So actual ventilator of Draeger started with the pulmotor in 1909. Heinrich Draeger, he was the inventor of Draeger company and Draeger ventilator, patented his first ventilator with the name of pulmotor. So this was the first positive pressure ventilator device. A tilted head position along with the recoil pressure to prevent gastric insufflation of air, aided ventilation, and the unit was used. So drawback of this, there was single circuit, so there was high risk of CO2 retention and technical difficulties were there. So later on, subsequently, Heinrich Draeger's son invented and modified his pulmotor unit, and there were dual circuit pulmotor were developed later on. So we will not go in detail. There is quite entire book on the history of Draeger ventilator. So this is just in brief. So now coming to the polio epidemic, you can see on the pictures on the right side, there are so many patients being ventilated in this tank ventilator in epidemic in California in 1953. So in Los Angeles in 1948 and in Copenhagen in 1952, negative pressure ventilators were extensively utilized. And initially there were very high mortality in early days. And thereafter, they started using puff tracheostomy tube for the first time and started ventilating patient outside the OR operating room, and then they noticed mortality went down from more than 80% to less than 30%. So polio epidemics in Denmark and USA show refinement of many principles of positive pressure ventilation as well, started with negative and then with positive. So this is quite interesting representation. You can see history wise, there is so many inventions from 1840 to 1960 in anesthesia, while very little innovation in life support. But in 1960, both life support and anesthesia have been merged in polio epidemic. And then outside also operating room, there have been increasing use of ventilatory device and further evaluation of ventilator and further development of intensive care unit, respiratory care units. So this is also very interesting chart from Massachusetts General Hospital between 1958 to 1982, showing the number of patients mechanically ventilated for more than 24 hours and number of patients survived. So you can see initially there were less number ventilated and less number survived, and over a period of time, more patient ventilated and more survived. So definitely we learned from experience. So now moving forward to another favorite ventilators, Bennett and Bird. They have been evolved in World War II. In 1915, response to increasing demand, Ray Bennett and colleagues developed accessory attachment with which it became possible to intermittently administer positive pressure breath in synchrony with negative pressure breath, and delivered by tank ventilator, which resulted in substantial reduction in mortality. End of the Second World War, Bennett valve was used to regulate the flow of gas within mechanical ventilator, which was originally designed to enable pilots to breathe comfortably at high altitude. So from Forrest Bird, he was also aviation specialist. So his aviation experience led to the design of Bird Mark 7 ventilator. So further innovation after World War II, Command and Maloney and Wittenberger made important observation on hemodynamic effect of ventilator. So in mid 1950, there was a concept of control mechanical ventilation was emerged, and Armstrong paper was published in 1963. He has defined control mechanical ventilation as complete substitution of spontaneous ventilation of patient by taking over both ventilatory work and control adequacy of ventilation. So Armstrong developed ventilator model in which minute ventilation can be set. So this was the first actual ventilator in which we can set minute ventilation. which was done by setting the respiratory rate within a given minute ventilation, which determined the backup tidal volume. So what we are doing now, we are setting the tidal volume and respiratory rate, which is setting the minute ventilation. Here it was opposite, minute ventilation and respiratory rate, which was defining the tidal volume. So further improvement in the design of Bennett ventilators saw the emergence of familiar Pruitt and Bennett machines. And popularity of Bennett and Bird ventilator in USA soon came to be rivaled by the development of volume cycle piston driven ventilator. And while Bennett and Bird ventilator were pressure cycle. So this volume preset immersion ventilator better guaranteed tidal volume and potentially recognized and potential anesthesia machine, as well as a respiratory device for long-term ventilatory support. So now all this we have evolved from pumping bellows manually, then iron tank, then further innovation in iron tank, curas, and then definitive ventilators, and then this dragger pulmotor and Bennett and Bird ventilator, Puritan Bennett machine. Now became more conceptual evolution occurred after 1950, then technical evolution apart from microprocessor. So toward the end of 1960, new disease ARDS was recognized, and there was increasing demand of respiratory ICU. Use of PEEP for the management of ARDS patient highlighted principally through Asbach and Patty's revival of Walton and Brach's concept of 1930. So they defined the use of PEEP for the ARDS, and PEEP was being started use from 1960 onwards. Now this was all for adult patients. So in 1971, Georgery et al. Applied continuous positive pressure to the care of neonates with neonatal respiratory distress syndrome and showed that pediatric mechanical ventilation was possible. So here started the history of starting ventilators in neonates and pediatric population. Now, moving forward from this history, history of ventilator-induced lung injury is also there. How conceptual evaluation has been there in Wiley principles. So initially, ventilators were invented to ventilate the patient with normal lungs, but subsequently they found to cause barotrauma, volutrauma, oxygen toxicity, and biotrauma when used in diseased lung. In 1940, MacLean and MacLean discovered the mechanism leading to the development of pneumothorax and barotrauma. Then in 1960, oxygen toxicity was discovered. In 1997, biotrauma, how biotrauma occurs from all this oxygen toxicity, barotrauma, volutrauma, this conceptual evaluation was occurred. And then in 2000, ARDS-NET large trial has been published, which has shown the benefit of lung protective ventilation. So traditional 10 ml, 12 ml per kg volume are not beneficial, and it is more harmful. The concept evolution occurred with ARDS-NET trial. So now coming forward to our modern ventilators, today's ventilator have evolved from simple mechanical device into highly complex microprocessor control system, which requires professional biomedical engineer have been playing quite a long role rather than mechanical engineer or other. So now process is more for making patient ventilator interaction more smooth than just developing more and more ventilator. So over the last century, modern ventilator have been evolved in terms of alarms, graphics, exhalation valves, use of microprocessor, improved triggering, better flow delivery, and development of new modes of ventilation. So in 1980 and 1990, there is a paradigm shift from controlled ventilation to partial ventilation and then to pressure support ventilation. So focus has been there in improvement of patient ventilator synchrony. So improvement beyond ventilator occurs in terms of not improvement in machine itself, but improvement in our understanding of pathophysiology of ventilation, both the good as well as bad. So lung protective ventilation, ventilator-induced diaphragmatic dysfunction, patient ventilator synchrony, use of positive and expiratory pressure, PEEP, role of driving pressure, extracorporeal life support, that is ECMO and extracorporeal CO2 removal, proportional assisted ventilation, NAVA, and smart ventilator with auto mode. Many things have been developed. Apart from this, all early 2000, HFNC, high flow nasal oxygen nasal cannula, was first introduced in clinical practice as non-invasive system to manage apnea in premature neonates. Since then, it has been widely used in pediatric population, particularly in bronchiolitis exacerbation. So over the last 10 years, HFNC have been used widely in the adult population for various indications. So we will not go in detail of HFNC and details of adult trials, but since last 10 years, it has been used and many more indications are coming for HFNC as well. So we can discuss subsequently in the end. So now coming forward to the ECMO, how ECMO has been evolved. So history of ECMO is also quite old. Discovery of circulation started in 17th century up to 19th century. There have been many evolution in concept. In late 17th century, there have been first centrifugal pump was developed by Danish Pepin, and it was the first mainstay of ECMO pump. And from 19th century till now, ECMO has been used more and more increasingly. Initially, it was functioning as support device for patient in cardiopulmonary bypass in 1950. But as technology progressed, Dr. Solomon in 1971 successfully treated a patient with acute respiratory failure with extracorporeal bypass circuit. So this was the first case of ECMO outside the cardiopulmonary bypass. And thereafter, 1978, Gattinoni reported use of extracorporeal CO2 removal to decrease the ventilator-induced lung injury. Then 1989, Extracorporeal Life Support Organization was founded, also was founded. And in 2000, there have been many cases in H1N1 epidemic, ECMO was used, and then Caesar trial was published, which was showing that centers, tertiary centers where protocolized care is there, outcome are better, not definitely due to ECMO, but any center with ARDS protocol and facility of ECMO is there, outcome are better. Then in 2018, EOLA trial published. There is no mortality benefit in EOLA trial as well, but there is increasing use after this COVID pandemic. ECMO has been used extensively in COVID-19 as well. So now too much about positive pressure ventilator since last 10-20 years. But in 2021, this innovative ventilator has been introduced, Exovent, which is negative pressure ventilator. You can see on the left side. Chamber consists of the base fitted on the standard hospital bed with own mattress and removable top that fits over the torso with neck and hip cells, and freestanding pump unit which is connected to the base by flexible hose, and control unit which allows the following settings. A background pressure up to -20, that is CNAP or NEEP. Peak inspiratory pressure -25, respiratory rate between 0 to 20, and I ratio between 1.1 to 1:1 to 1:5. So Exovent also used traditional iron lung technology to breathe without being sedated, but design is better than iron lung and PURAS. So just brief about negative pressure ventilation. Is there any role of negative pressure ventilation? Though there is quite controversial. Some group of doctors still supports negative pressure ventilation, but there is no much evidence comparison to positive pressure ventilator. But definitely hemodynamics and more physiological, better hemodynamic, less sedation. So all these pros are there with negative pressure ventilation. So chronic neuromuscular disorder with chronic respiratory failure, COPD, there is some role, ARDS plus or minus. There are some case reports and some papers showing benefit, but widespread use is not there in ARDS as well. There are very few cases and case series. So in summary of generation of ICU ventilator, first generation between 1900 1970, only volume control ventilation. Second generation mid 1970 to early 1980. So first appearance of patient triggered operation. So spontaneous breathing is encouraged. Third generation of ventilator between 1980 to 1990. Microprocessor has been evolved. And fourth generation between late 1990 to present. There is variety of ventilators and plethora of ventilatory modes. In future, only time will tell. Algorithms. So at the end of 21st century, we are confused with so many things. So only time will tell what will occur in the future. So journey continues from these ventilators to modern ventilators. So I would just request Sumit sir to summarize this history and evolution of ventilator, and then we can move ahead to next presentation. Just in future, what we can see is not only just more newer ventilator or newer modes, but we can see evolution of negative pressure ventilators as well, or we can see beyond ventilators principles to avoid intubation, early ambulation, minimizing sedation, more end of life care, and extracorporeal life support. So over to you, Sumit sir.
Thank you, Vitrag, for a comprehensive, comprehensively taking us through the history of ventilation, mechanical ventilation. For me, history is a very interesting part. For many of us who are doctors, may not, or healthcare providers, it may not be of great interest. But the interesting part is, even if we don't go into the specifics, the interesting part is that it tells us the thought process which went behind the certain developments that happen in any field of science, technology, medicine. The other thing is, which is important, is if you will realize that if you see at a certain point of time, at the similar time period when in history, the mention of tracheostomy in the Egyptian civilization and the Indian civilization, the Greek civilization, which are at the parallel time, happens parallelly. And this is true of most technology, that it takes a certain kind of socio-economic, technological knowledge to develop a certain kind of science. It does not happen in vacuum. Just one brilliant thinker does not produce a scientific innovation by itself. It takes more than that. And that is why you will see at different time points. And if you see the 18th century and the 19th century and the 20th century, the similar patterns of development of ventilators is happening in equally developed societies, which are now Europe and North America. Earlier, when it is happening, it is in Greece, Southern Europe, Greece, Egypt, and India, right? And China probably, which we don't know too much about. So it, you don't have a Pushpak Vimana out of the blue. It doesn't happen. It happens with a certain development of technology and socioeconomics, that similar periods of history with similar civilizational development, similar kind of products arrive, right? So that's what history tells us, that technology doesn't happen in a vacuum. It doesn't happen by just individual brilliance. It happens with progress of science and thought process based on the technology that we have and the knowledge which we progressively develop. So those are the most important things out of the lesson of history in general about medicine or of science. Along with that, as you can see, the different paths that could have been taken for developing positive pressure versus negative pressure ventilation. Negative pressure ventilation, as most of you know, is the more physiological ventilation, but because of the technological challenges that was there to develop it, and the patient comfort and the size of the machines, the path which was relatively easier at that time, which was positive pressure ventilation, that is the path that science took at that point of time. But at certain point of time, probably to be more physiological, we have to find better ways to develop negative pressure ventilation, the reduced need to actually intubate, paralyze, etc. All these elements will come together. Unfortunately, for negative pressure ventilation, what has happened is only a small group in Italy is the one which has worked on this technology a lot. And so it has not been what we call in science as externally validated. Most of the studies, if you see, have come from Borini et al. And that is true of a lot of things that we do. Many a times, one study comes from one single center saying this technology or this medicine this technology or this medicine is, works exceptionally in this center. But unfortunately, that same thing may not be externally validated. So woe of science is that whenever you do research, whatever is being proven has to be proven not only in one or two centers, but it has to be externally validated. It can be extrapolated to other centers also. So all these things are the part of our understanding. That is why the history of mechanical ventilation was, that's why Vitrag spoke about it, is to make us understand that science does not happen in a vacuum. I would now like Dr. Jigi Devetia, who is, who is the head of critical care at Tata Memorial Hospital. Now he's the director of Cancer Hospital at Ludhiana. He has been ex-president of the Indian Society of Critical Care Medicine. He has been teacher to many generations of students, I would say, in critical care. I would like him to speak a few words. He's there as the mentor here. If you could put in a few.
Sir, Arindam here. But before
Okay.
you leave and Jiggy sir also come, both of you, if you please share your personal experience. Both of you had been initiated critical care way back in the 90s, both of you, and you are almost contemporary, I would say so. So if you also say the evolution of the techniques of ventilation, what we initially started and how we have evolved, if you share a few words on that.
So before it goes over to Jiggy sir. So
I think both of you can say together, sir. It's not a name. Or you can add on the letter also. It's up to you, sir.
Let Jiggy sir speak on it, and I'll add. Right.
Okay. Thank you, Sumit. Thank you, Arindam and Dr. Vitrag. That was a very nice presentation. I was actually quite fearful about what I would listen in a history lecture of ventilation, but actually it was extremely interesting and very nicely put together. And I think there are two things which sort of stood out. One is the development or the history of the development of the technology of ventilation, and at the same time the development of the biology of ventilation. So I think the first few decades may have been spent in developing the technology, the different types of ventilators and the switch from negative pressure to positive pressure ventilation, which was a sort of a huge shift, isn't it? I mean, that was the big paradigm shift which sort of took place and has laid the foundations for what we do today in mechanical ventilation. But then the big switch, I think, was the understanding of ventilator-induced lung injury. And now the focus is shifting, apart from modes which improve patient comfort and synchrony and so on, is how do we minimize or prevent or reduce ventilator-induced lung injury. So all your the low tidal volume ventilation, your ultra protective lung ventilation. So that I think we covered that sort of shift in thinking extremely well. And Sumit pointed out that, it's not just one person or it's not just one, occasionally by serendipity, it's one thing which sort of triggers off interest in one particular direction. But I think what we've seen is the evolution of the biology, our understanding of the biology of ventilation, which is actually making differences to outcomes today. And you mentioned what is the future, and the future is going to be probably more towards lung protection, negative pressure ventilation. There is some rekindling of interest, like you pointed out, but I think there is also a lot of interest in developing extracorporeal technology so that you rest the lungs and you don't actually damage the lungs by more ventilation, whether it's negative pressure or positive pressure. So I think it's going to be very interesting to see how biology and the progress of ventilation rather than the ventilator sort of progresses. So we also, to put what Arindam was speaking, we've seen, at least I've seen from the Ambubag to the Birds ventilators, and then the Puritan Bennetts with the bellows, and finally now the modern microprocessor ventilators are concerned. And as far as the ventilator technology is concerned, I think doctors have to collaborate more with biologists and with engineers, because the technology is, everything is controlled by microprocessors, everything controlled by algorithms, and all your future smart ventilators, whether you use them for weaning, whether you use them for automation, or whether you use them for using artificial intelligence and use bioinformatics to sort of figure out what sort of changes are taking place in the genome or in the metabiome or whatever it is, put all that together, I think that's going to be the future of ventilation. But all in all, it was an extremely interesting session, and our understanding of ventilation has changed. And just like we talked about lung injury in the setting of ARDS, the concept of auto PEEP and dynamic hyperinflation has dramatically altered the way we look at ventilating patients with serious COPD, exacerbations, or asthma. So, when we were medical students or even anesthesia postgraduates, we were taught that weaning a COPD patient is extremely difficult. एक बार COPD गया ventilator पे वो निकलेगा नहीं, वो सीधा graveyard में जाएगा on the ventilator. But I think our understanding of auto PEEP and all those sorts of things have significantly improved the way we ventilate patients with COPD, and we can wean them up fairly comfortably. Non-invasive ventilation. So all these sort of things have made a big difference in the way we are looking at patients and looking at ventilation. And there was a talk by Gattinoni some time back when he said that intubation may become obsolete. First, you've got non-invasive ventilation, HFNC, and now you may have extracorporeal techniques. In COPD, certainly they seem to be very useful. In ARDS, we'll see what happens. But I think it's all very interesting. I think you laid the stage for a nice understanding of how technology and biology has progressed, and the future, the sky's the limit. So we'll see where it goes.
Thank you, Jiggy sir. I just, adding to this, whatever what Jiggy sir said, as he said, the biology, our understanding of the pathophysiology of disease has also led us to, if you see how the less we do sometimes, the less is more, as more and more concepts in every, many things that we do in critically ill patients is also as important in critical care and extracorporeal removal of carbon dioxide, etc. And the least amount of damaged and the shift which the understanding of disease process has done to how we look at ventilation. So the shift from just a technological understanding to a pathophysiological understanding, as Dr. Divya said, that is a major shift. And what we will also get in the near future, along with more extracorporeal removal, etc., is of carbon dioxide or oxygenation, is also what we call precision medicine subgroups who will require different patterns of ventilation, different patterns of support. So subgroups which will be different, and this is the subgroups that are being now teased out, the phenotypic subgroups, the genotypic subgroups, which are now being teased out from the biomarkers, from the way they interact with the ventilator, and also from large data sets. Large data set analysis with, which is going to tell us which is the subgroup of patient where you use this kind of ventilation, this kind of support, be it this or the other, and which is the subset you will require a different, form of ventilating, because these subset of patients will react differently, even in ARDS, suppose, or even in COPD. Different subset of patients will respond differently to different kind of settings in the ventilator. This is the other development which is going to tell us also in the future how to ventilate or take care of the gas exchange of patients in one way or another. So I think Arindam, you can.
Yes, sir. I think I love the way Jiggy sir mentioned the word serendipity. Right? It's a beautiful term. I think a lot of people will now try to find out what is the meaning of it. It's an NNA, and also he very aptly mentioned that it's not about only the technology. Our understanding also grew side by side. Previously, we thought to save lives by giving more, and as you said, sir, that now we save lives by giving less or sort of refraining and restraining ourselves. So after you two so seniors speaking on it, I won't like to add anything. I would just say that, Mitra, carry on the next session and give us an introduction of the ventilation, because till now we had only dwelt on the physiology, the understanding, the history, evolution, and all the 5 classes that we have done. You are going to set up the tone now, and the next 22 classes would be mostly on clinical aspects only, and maybe 1 or 2 classes would be at the end on the future, which Sumit has said on precision ventilation or individualized ventilation, which is going to be the flavor, or more and more artificial intelligence coming into decision support systems. So over to you, Vitrag, you please continue.
Hello. Thank you, Arindam sir. I will start with introduction to mechanical ventilation. So let us start with the introduction. So first, what is the indication? Why someone needs the ventilator? So if in simple language to put it out, patient cannot be oxygenated. So there is low PO2 or low SPO2. Patient cannot be ventilated. So there is high PCO2.
Vitrag, we can't see your slides. Sorry, we can't see your slides.
Just a minute. Let me share it again, sir. Is it visible now, sir?
Yes.
Okay, sir. So I'll just repeat again. So we will start with indication why patient needs a ventilator. So in simple language, a patient cannot be oxygenated. So low PO2, low SPO2. So it can be pneumonia, it can be ARDS, or any other etiology leading to hypoxia. So patient cannot be ventilated. That can be another reason. High PCO2 or respiratory acidosis. So it can be COPD, asthma exacerbation, or any other reason which is due to inadequacy of ventilation. There is a respiratory acidosis. Or patient cannot generate enough tidal volume due to nerve or muscle weakness. So any neuromuscular weakness like GBS or any myasthenia gravis or any other condition due to neuromuscular weakness is there. High PCO2 and low SPO2 is there. Or patient cannot protect airway. So poor GCS, head injury patient, stroke patient, or any other septic metabolic encephalopathy, patient is not able to protect the airway. And if we are not sure patient is dicey whether he will require or not ventilator, so always for patient's benefit, put patient on ventilator. So patient needs a ventilator whenever you are in dilemma to be on safer side. So these are the simplified indications. So now there is just brief about negative versus positive pressure ventilation. So what is the main difference between negative and positive pressure ventilation? Negative pressure ventilation is physiological like spontaneous breathing. It works by exposing the surface of thorax to subatmospheric pressure during inspiration. So this causes the thoracic expansion and decrease in pleural and alveolar pressure. So in spontaneous breathing also, pleural and alveolar pressure is decreased during inspiration and creates pressure gradient for air to move from mouth airway opening into the alveoli. So when the pressure surrounding the thorax increase and become atmospheric or greater than that, expiration occurs by passively by elastic recoil of respiratory system. And inspiratory changes with negative pressure ventilation, as I have told, it mimics the spontaneous breathing. And in positive pressure ventilation, pressure higher than atmospheric pressure is applied to intra-alveolar space during inspiration. So it is not over thorax, it is intra-alveolar space. So again, you can see on the right side schematic representation. And what are the pros and cons of the same? Pros is intubation is avoided. It is non-invasive. Patient can talk. Patient can eat. There is no sedation or minimum sedation requirement, and it is physiological. So venous return would be improved. But what are the cons? Left ventricular afterload will be increasing, and regulation of respiratory parameters, including IE ratio, would be difficult. Just a minute, there is a technical problem. Sorry for inconvenience, just a minute. Sir, meanwhile, I'm just getting my updated slide. Meanwhile, can you summarize your views on negative pressure ventilation and negative versus positive pressure ventilation?
So, yeah, Vitraj. So basically, as you said, it's supposed to be more physiological, and as we were discussing, so negative pressure ventilation, it basically it works by the, I mean, it has different modes like positive pressure ventilation. You have positive pressure support, you have intermittent positive pressure ventilation, you have a positive pressure ventilation, negative pressure ventilation. You have negative pressure ventilation, which is like pressure support with CPAP. You have, in place of that, you have negative inspiratory pressure support and negative expiratory pressure, which could work like a pressure support CPAP kind of combination that you have. So all these possibilities are there. The problems are, as Vitraj will emphasize, are for different, as he said in the previous lecture also, that there are problems with negative pressure in spite of it seeming being more physiological. At this present moment, the evidence towards supporting it is not very strong. It in pulmonary edema, in patients of heart failure, etc., it would be counterproductive probably to a certain extent, though it has been shown to have, in small studies, shown to have some degree of benefit in ARDS patients and in COPD patients. But the evidence base is very small. Positive pressure ventilation is something we have got used to, the physiology, the understanding of it, its role, and as you know, there are broadly two broad mechanisms to deliver a breath. Either it can be a volume breath or a pressure breath, which Vitraj will be talking about. And these were the two large pathways that positive pressure ventilation developed in, and the role of PEEP and its role in both major forms of lung disease, which is either the ARDS pulmonary edema end, or the COPD bronchial asthma end. And this would be the major kind of targets of change that you are looking at. I would like, I think it's, without the slides, it's difficult to explain how negative pressure and positive pressure, and now Vitraj has the slides to explain it better. So I think I would like Vitraj to take over with the slides and explain how negative pressure works beyond as opposed to positive pressure. Vitraj.
Thank you, sir. Thank you for lucid explanation. So here, airway and intrathoracic pressure during positive pressure and negative pressure, we can see on the upper side it is positive pressure ventilation, on the lower side it is negative pressure ventilation. This is chest wall pressure, the PCW, PMUS is muscle pressure, PPL is pleural pressure, this is PALV is alveolar pressure, and this is airway pressure. So what we can see is this pressure between muscle pressure and airway pressure, there is subatmospheric negative pressure is created in negative pressure ventilation. You can see on the slide figure below. While on the upper part, you can see it is neutral and positive, not negative. So there is exactly physiological spontaneous changes. There is negative pressure inside the alveolar level during inspiration in negative pressure ventilation and physiological respiration. While in positive pressure ventilation, it is exactly opposite. It's less positive in inspiration, and at the end inspiration, it is more positive. And at the end of expiration, at alveolar level, pressure is 0, or as per PEEP, we have set the PEEP. So we can move forward to the type of ventilators. So the type of ventilation is negative and positive. So type of ventilator in negative, it is iron tank, QRAS and exovent, and type of positive pressure ventilator are home BiPAP, portable BiPAP, ICU ventilator and HFNC. And another thing is ECMO, that is totally different. So this is just the introduction to the machine. You can see this is the ventilator itself with screen showing graphics, diagram and everything. This is the expiratory valve, flow sensor, and this is the HMA filter on the expiratory end. This is the expiratory limb of circuit. This is inspiratory limb of the circuit. Here is the ETCO2 adapter. Beyond that, it's HMA filter. Beyond that, it is catheter mount. Then at the wipe is ET tube is connected, represented with ambu bag in this slide. And this is the oxygen inlet on the back side going to the back of the machine. So this is how modern ventilator works. So there are various modes of ventilation in our modern ventilator. So it's either volume controlled or targeted, that is CMV or IPPV, either pressure controlled or targeted, that is PCV, or it can be assist control, that is breath is triggered by patient, not by time. Or it can be synchronized intermittent mandatory ventilation, SIMV, with SIMV volume control or SIMV pressure control. Or it can be simple pressure support ventilation, spontaneous breathing mode. Or there can be dual modes like PRVC, auto flow, PRVC in most of the machine, auto flow in dragger. Both have some differences in technology, but overall outcome is same. Or volume assured pressure support or proportional assist ventilation. Or advanced modes like APRV, bi-level support, BiPAP, NAVA, etc. So how ventilatory modes are defined? They are defined by TLC, that is trigger, limit and cycling. So trigger is the initiation of respiration, and it can be either time triggered or patient triggered. Time triggered in control mode like CMV, IPPV, PCV, and patient triggered in assist control or support mode like pressure control mode or volume control mode or pressure support mode. If patient is triggering the breath, then it is called assist control in control mode, and if it is spontaneous mode, then it is pressure support mode or CPAP. Now, what limits the respiration? What limits the ventilation? So whatever values we set in the ventilator, like set the tidal volume of 400, set the flow of etc., set the inspiratory time. So all these are our target or limit, which stops or limits the inspiratory flow. And what cycles from inspiration to expiration? So cycling, it's opening of expiratory valve and initiation of expiration. Like in certain ventilator, you can see expiratory trigger, that is a percentage of peak inspiratory flow. So supposedly from example, from 100% to 30% decrease in peak inspiratory flow, expiratory valve opens and then initiate the expiration. So sir, should we discuss this in the last, or you would like to give your views on trigger, limit and cycling right now?
I think there is a session on ventilatory modes, Arindam. So the basics of ventilatory mode. So I think you have explained it. So I think we can go ahead. Yes.
Okay, sir.
If you have questions, we can deal with it.
Okay, sir. So there are two ways to give a breath in ventilator, either volume targeted or pressure targeted, and either can be used with control mode or assist control mode or SIMV mode. So either it is volume or pressure, and it can be controlled or assist control or SIMV. So this initial ventilator settings in any mode, we would keep this. We will not go in detail, but just for basic, for introductory part, mode would be assist volume control or pressure control, or rate would be 12 to 20 depending on the baseline minute ventilation. Usually we keep 70 to 80% of baseline minute ventilation to match that kind of minute ventilation. Tidal volume 6 to 8 ml per kg to keep tube pressure less than 30. And in pressure mode, inspiratory pressure to generate the same tidal volume, it should be less than 30. And P between 3 to 10 depending on the blood pressure, hypoxia and compliance. Usually we start with 4 to 5, and we can increase in ARDS patient as per PEEP titration. FIR to initially start with 100%, and then we can decrease every 5 to 10 minutes if lungs are normal. We are not intubated for ARDS as per SPO2 and PO2. And inspiratory time to keep IE ratio 1:2 to 1:3. 1:1 in ARDS, 1:3 to 1:4 in obstructive airway disease, but in general we try to keep it 1:2. So we have discussed the basic ventilatory mode. We have discussed the trigger limit cycling indication of generalized indication of ventilation. Ventilation indication and contraindication are different from in general ventilatory invasive ventilator. Moderate type 1 respiratory failure, very limited role in selected subgroup of ARDS patients. But significant role in acute LVF, pulmonary edema, fluid overload, etc., obstructive sleep apnea, or acute hypercapnic respiratory failure in COPD or neuromuscular disease, or any patient with pH between 7.25 to 730 with acute hypercapnic respiratory failure. But if patients are not responding to medical therapy with PO2 less than 50 and PCO2 more than 80, and pH is less than 7.2, so ideally patient may need intubation anytime, but we can avoid intubation and start on non-invasive ventilation if following conditions are met. Patient is sick but not moribund, patient is able to protect the airway, patient is conscious and cooperative, patient is hemodynamically stable, there is no excessive respiratory secretion, and there are few comorbidities to the patient. So if these all parameters are met, we can try with NIV and keep SOS intubation ready and invasive ventilation ready. Or we can use NIV in patients who have declined intubation and still want to opt for other treatment. Or we can use as weaning facilitator and shorten the invasive ventilation duration. It can be used as post-extubation or post-surgery respiratory failure as well. Or it can be used as home non-invasive positive pressure ventilation for recurrent admission of COPD exacerbation or neuromuscular disease patients. So this is nice chart from British Thoracic Society guidelines showing all indication, contraindication, settings, and monitoring all. So there are separate lecture for that. We will not go in detail. So in general, contraindication to mechanical ventilation, there is no absolute contraindication for invasive mechanical ventilation, except in certain scenario like end of life care, do not resuscitation, pneumothorax. It should be decided individually, case to case basis. And pneumothorax is there, like in patients with polytrauma, we would like to put ICD first, and then we can intubate unless it's life-saving. But even in life-saving condition, we will put a needle first to drain tension pneumothorax, and then we will initiate on positive pressure ventilation. What are the contraindication of non-invasive ventilation? It's definitely cardiopulmonary arrest, cardiac arrhythmia, impaired mental status, low GCS, so high risk of aspiration, facial trauma, facial surgery, so we cannot use mask, upper airway obstruction, patient is very uncooperative, excessive secretions, high risk of aspiration. So all these are contraindication to NIV. So now moving forward to what are the complications. So complications are ventilator-induced lung injury, which we have already discussed in brief in last presentation. Hypotension due to decrease in preload and in volume depleted patient and in patient with high dose of sedation mainly. Stress ulcers and ventilator-associated events. So CDC has clearly defined all these events, which includes ventilator-associated complication, infection-related ventilator-associated complication, and possible ventilator-associated pneumonia or probable ventilator-associated pneumonia. That is why. So what is the CDC definition of ventilator-associated event? So ventilator-associated condition is defined as increase in oxygen requirement sustained for minimum of 2 days in mechanically ventilated patients. And day 1 is index day where ventilation is started. So that day 1 and day 2, so minimum 48 hours patient is on ventilator, and before that baseline FiO2 and PEEP requirement were stable or improving, and then for 2 days sustained increasing PEEP or FiO2 requirement, then it is called as ventilator associated condition. So any condition, barotrauma, volutrauma, ARDS or infection which is leading to VAC. Now infection associated ventilator associated condition. So patient with VAC with clinical sign of infection, that is fever or leukocytosis, and it is on the day 3 of mechanical ventilation, on or after day 3 of mechanical ventilation, and within 2 days before or after the onset of VAC. So it can precede the VAC, IVAC can precede the VAC, but it should be after 3 days of onset of ventilation and within 2 days of VAC. And possible and probable VAC are respectively defined by presence of infection associated ventilatory condition and laboratory or microbiological evidence of infection. So what is the laboratory or microbiological evidence of infection? So this is the CDC slide showing definition of all ventilator associated condition, infection related ventilator associated condition, and possible and probable VAC. So IVAC plus any of these criteria equal to VAC. So criteria one is positive culture from one of the following specimen meeting quantitative or semi-quantitative criteria without requirement of purulent respiratory secretion. So either ET aspirate 10 to more than 5 colony forming unit, bronchial alveolar lavage 10 to 4, and PSV protected specimen brush more than 10 to 3 colony forming unit, along with infection related ventilator associated condition is called VAP. Criteria 2, this condition is not as in criteria 1, but purulent respiratory secretions are there and organism is identified in PSD or BAL or ET aspirate, irrespective of colony forming unit quantitative results. So what is purulent respiratory secretion? It has been defined as more than 25 neutrophils and less than 10 squamous epithelial cells. So whenever we ask our microbiologists regarding sample adequacy, we always ask how many neutrophils, polymers they found and how many epithelial cells they found. To avoid there is any contaminated sample, saliva has been sent or proper adequate sputum sample has been sent or not. In criteria 3, organism identified from pleural fluid, any biopsy or lung biopsy or Legionella diagnosis with antigen test, or any PCR diagnosis of influenza or respiratory syncytial virus or any organism identified in biofire, along with IVAC, that is called possible or probable VAC. So ventilator induced lung injury, we have already discussed this, so we will not go in detail, but just to summarize, VILI occurs at two extremes. Upon reaching the total lung capacity at the end of inspiration, barotrauma or volutrauma occurs, and to prevent it, we have to limit our tidal volume to keep plateau pressure less than 30. And at the end of expiratory lung volume, that is beginning of inspiration, atelectotrauma occurs by stress or shear pressure in lung units that open cyclically and close. And to prevent this, we have to open up all closed units together by recruitment and stop them from closing by using PEEP after recruitment to prevent de-recruitment. So this is already we have discussed volutrauma, barotrauma, atelectotrauma, biotrauma, which all leads to ventilator-induced lung injury. So now moving forward to economical part. So ventilator is quite economical burden. Once you say to any primary consultant or any patient relative that patient will require ventilator, so they have to get mentally prepared with the length of stay and total cost of ventilator. So just minimum cost to start the ventilator in any tier 2 city would be, ventilatory cost would be 3,000 to 4,000 depending on your hospital policy. Ventilator circuit, any standard circuit cost would be more than 1,000, at least 1,500 to 2,000 of most of the company. Then 2 HMA filter which will be used, one on the expiratory end and one on the patient end. So 500 into 2 HMA filter, then 1 catheter mount to give more flexibility. That adds more 500 rupees, and closed suction catheter ideally advised if patient is going to require ventilator for more than 48 hours, which cost approximately 1,500 to 2,000 or beyond that. So approximate ventilator cost to start with 8,000 fixed cost on initiation on day 1, and every 72 hours we have to replace HMA filter. SOS we have to replace circuit or catheter mount is soiled in between, and closed suction catheter also we have to replace every 4 days. So this cost keeps increasing and adds a quite total burden on patient bill. And variable cost which we do not consider, but it's definitely contributed by ventilator due to limited mobility and aspiration risk, VAP risk, stress ulcer risk. So antibiotic, anticoagulation, PPI, IV fluid for suction and flush, all these are attributed to increased cost on patient with ventilator. So if patient is in ICU without ventilator, then with ventilator, 10 to 15,000 is the minimum cost per day which patient will have to bear. So ethical issues, apart from cost, there are ethical issues. Some patients do not wish to get on ventilator. Some patients relative do not wish and opt for palliative care. So till recently, we do not have much Indian guidelines, and it was in gray zone whether to resuscitate or not. But at least not for withholding or withdrawal of treatment, there is much clarity, but there is now enough clarity on CPR, that is, do not attempt resuscitation, ICMR consensus guidelines. So it relates only to CPR and it has limited value in certain situation only and not to other form of treatment. And whenever in doubt, we have to perform CPR as per clinician desire and opinion. And while communicating, treating physicians should explain that patient would continue to be provided all treatment intended for potentially be curable condition or to reverse potentially be a reversible condition and provide supportive care. So if any condition is reversible, then we have to explain that we will provide all the treatment required and we will continue CPR if it is reversible. But if it is futile, it is not reversible, then at least we have legally one option now to explain the relative and document it, and we can opt for do not resuscitation. But it does not mean do not withdrawal or withholding the life support treatment like no intubation or removal of PT tube or ventilator. But there are some gray zones in our law and we can definitely use that as well. So we will discuss that with our mentors Sumit sir and Divatya sir in the end. So I would like to finish my presentation on introduction to mechanical ventilation with this. These are my references, and I would like to thank Sumit sir for his quite help. And these are the main articles which has been used for the slides. If any question, then you can reach me on this number. I would like to hand over to Arindam sir and my mentors Divatya sir and Sumit sir for further discussion. Sir, please give your views on the cost, on views on ethical aspects, withholding of treatment, withdrawal of treatment, and anything you want to add on. Hello. Sir, please summarize and give your views on ethical aspect and economical aspect of ventilator.
Okay, so Dr. Sumit has left, is it? Okay, I thought he was there. So, you know, economical aspect and ethical aspect are both little touchy topics to speak about. Economical depends a lot on which sort of setup you're working in and what your hospital charges. And we also have to understand that ventilation is not the only thing that a sick patient gets. You know, he may be, because I mentioned some antibiotics and other drugs and all he may be getting, but sometimes they will be requiring dialysis, they'll be requiring maybe some surgical procedures, they may be requiring endoscopy. You know, so there are multiple things that happen and it's very hard to predict the cost. The ethical aspects are a little more difficult, but actually probably extremely important. And in some ways, economics and the question of whether or not to ventilate or continue ventilation are linked, because inability to pay is very often a trigger for the family to tell you ki abhi aur kitna lamba chalega, and you know that will he ever get better. On the other hand, there are other families who got tons of money or lots of insurance and they don't care what's happening. They say you keep on trying, do whatever you want, when actually the situation is not very, is quite hopeless. So, but if you just look at the ethical aspect, whether a patient can pay or cannot pay, if he is salvageable, has a potentially reversible condition, and then we should try to save the patient. If he is non-salvageable, whether or not he has money, we have to explain to the family that the outcome is not going to be good, and at some stage you have to think of either withholding or withdrawing care rather than going on escalating, all sorts of support, whether it's ventilatory support, ECMO, and with ECMO, that's become even more, the potential to prolong life is even more now with extracorporeal support, or whether you give vasopressors, inotropes, dialysis, liver support, so all those sorts of things. So the law is silent on all of these things. There is no law which tells you that you must ventilate each and every patient till they die, or the oxygen in your hospital gets over. And there is no law which tells you that you must not ventilate patients up to a point. The Supreme Court judgments have recently, they've all been in favor of withholding or withdrawal of care in futile situations, but they've laid down a procedure which is actually extremely impractical and not doable. And I think the key lies in that if you ask someone procedurally whether it's legal, it is technically legal as per the current rulings of the Supreme Court to withdraw, you have to go through a procedure. And if you look at it purely from that aspect, it becomes very difficult to undergo that procedure. But if you practice intensive care like we do, like in real life, you talk to families, you get a consensus, and very often you're able to do ethically the right thing by, with the consent of everyone and with the consensus of the treating team, the patient, the family, you can sort of withhold care. How the law will look at such a situation, no one will know unless we are sued for that situation, because we've not followed the letter of the law, that you have to take permission from here and there and go to this magistrate and then some other magistrate and then someone will come and that procedure is stupid and that's never going to happen. But we withhold treatment very often, and it's done in a nice way. Very importantly, it should not be chori chupe. You cannot quietly put off the ventilator or quietly turn the oxygen down to 21% when no one knows. That's how it has to be discussed, it has to be documented, and then it has to be done with consensus. Then ethically it is okay. Now, don't ask about medical legal because I'm not a judge and no one will be able to tell you what is going to happen. Okay. So there are a few questions for you, I think.
Yes.
Open your chat.
Yes, let me just open and okay. Indication of ABG in patient on ventilator, how many times per day? Dr. Zioko has asked that. So would you like to answer that, sir?
Want me to answer? So, I mean, if you have a patient who is stable on a ventilator, I mean, generally you need to do 1 or 2 blood gases a day, right? You also know that, again, it depends on how stable or unstable the patient is, because you have got your patients on a pulse oximeter, so your oxygenation is being monitored all the time. If you have end-tidal CO2, that's different, but you need not even do an arterial blood gas for PCO2. You can do a venous blood gas because the venous blood gas is very close to the arterial. And unless the patient is in shock or he's got severe circulatory problems, the arterial and venous CO2 are pretty similar to each other. So technically you can avoid a blood gas if your patients are stable. But if your patients are unstable, then you need to do a blood gas because odds are you will have an arterial line in any way for the hemodynamics. And then if your patient is requiring lots of increasing levels of PEEP, increasing levels of FiO2, the CO2 is going up, then it's better to have a blood gas and do it, whenever you're worried, whenever you make significant ventilator changes or you see significant deterioration, then you need to do that. And of course, your acid-base status, you can only know from an arterial blood gas. So there is no rule, but in our ICU, if the patient is stable, we do maybe once in the morning and, maybe not, and maybe once at night if someone wants to just check that everything is okay. But yeah, so that's but it depends on the general condition of the patient and all that.
So I forgot to add this in extra cost of patient on ventilator ABG. So we can add further 1,500. So
now you are talking of history. So there was a condition which was described in ICU patient was called ventilator anemia. And that is because patients on a ventilator undergo frequent blood tests. So it's blood gases or
ICU anemia.
biochemistries and this and that. So in a day, you draw almost 100 ml of blood, and about 4-5 days, you've done 500 ml of blood only for investigations. Right? So then you get what they call as respirator anemia. Anemia.
So, sir, exactly as you said, ABG is SOS only, even not daily. I think apart from ARDS patient who are being prone or who are on high ventilatory requirement, daily ABG is not required. I remember in my MD days, we were used to do daily or twice daily ABG of all ICU patient, even any patient who is on ventilator or tracheostomies for more than 3 weeks, who is having just sepsis and difficult weaning and all. So we have to ask question what we will do with ABG. We are going to do any change in the treatment or ventilatory parameter, then yes, we have to do, otherwise no. Because with ETCO2 and SpO2 and other vital parameters, we are getting our information which we can get in ABG. Change like new onset hypoxia, new onset worsening of shock, then definitely ABG is required. Otherwise, if you are proning the patient, changing the ventilatory setting, then definitely it is required, but not routinely. So no daily ABG. Second question is monitoring while ventilation. So I think there would be separate lecture for that on alarm scalar graphics and everything. So we will not be discussing that in detail. Another question is sedation protocol for ventilator. I think there would be separate lecture for that too. But just in brief, there is paradigm shift in sedation as well. Previously, benzodiazepine were widely used. Now there is more focus on non-benzodiazepine drug like fentanyl, dexmedetomidine, propofol, and we use midazolam less often or in less dose and less duration. So would you like to add anything, sir?
Yeah, so I think now we move to the concept of what we call as analgo sedation. So everyone should get some degree of analgesia. And midazolam and the benzos in general are not encouraged unless there's a specific indication for them, largely because we recognize the problem of delirium. Of course, we like to see our patients more awake rather than asleep. So as little sedation as is required for the condition of the patient. But if the patient is very sick initially, got a very severe pneumonia or a very bad ARDS, you may need to sedate heavily and then even maybe paralyze. But by and large, the dictum is to keep the patients as light as possible, avoid benzos as far as possible, and use drugs like propofol or dexmedetomidine because they have a beneficial effect on delirium as well. Right? So, and I'm sure there will be a separate talk on sedation strategies and so on. The one very important thing you need to keep in mind in sedation is, those prolonged infusions are not good, because when you give infusions of even midazolam or fentanyl, which are otherwise short-acting drugs, when you give as boluses, when you give very frequent boluses or you give infusions, they become long-acting drugs, and then they take a very long time to get off, and that impedes breathing. So you have to be very careful and monitor sedation.
Hello.
Like you monitor blood pressure.
आ जाओ. बंद कर दो.
Monitor blood pressure when you give vasopressors. You should monitor sedation and analgesia when you give these drugs, and keep it as low as possible, as compatible with the state of the patient.
Any other question?
One needs to keep their mute themselves.
I think someone.
Dr. Rai, can you mute?
Please, Daddy.
Yeah.
Please,
Okay, I've muted him.
You want to add anything, sir? I think there are no further questions.
Yeah, so they want some guidelines. If you come across any recent guidelines.
I think it was in continuation with sedation. I think guideline regarding what.
Yeah. So the latest guidelines are by the SCCM. They've given these what they call as PAD and sedation guidelines. Right. So you can read them, but I'm sure there will be a separate talk which you should attend. Okay, if there are no further questions, guidelines for monitoring. So, so you can divide that into monitoring the ventilator itself and monitoring the patient on the ventilator, the other aspects, right? So I don't think we should go into too much about other aspects like hemodynamics and so on, which you should monitor. But you want to talk about what you'll monitor on the ventilator itself?
I think same as you discussed. I think you want to ask monitoring parameters
If you got
patient
volume
on
controlled
ventilator.
ventilation, you know that the pressure varies. So you must measure the peak pressure and the plateau pressure. Because with volume control ventilation, if there's a leak, you will lose volume. You must also measure the expired minute volume and the expired tidal volume. Yeah? With pressure control ventilation, please remember there's no point in monitoring the airway pressure because you've set it, but you must monitor the tidal volume and the minute volume, because if there's a change in compliance or resistance, then the tidal volume will go down, and then you can get serious hypoventilation, or you can get serious hyperinflation if the condition of the patient suddenly improves. So you need to monitor the tidal volume extremely carefully.
There is separate lecture on respiratory mechanics, and the next lecture itself is about scalars and loops and all, I think. So it would be discussed in detail. Next question is
introduction, and all the questions are actually related to what all to do after that. So maybe you guys need to come back and
this was just to sensitize how ventilator and concepts have been evolved, and just to introduce you to the machine. So I think you are familiar with the machine, but just to sensitize. So now your journey would start, and actual ventilatory class would be from next session. So question is, HMA filter should be placed on inspiratory limb or expiratory limb? So definitely, as in this picture, you can see it's not for humidification. It is for protection, infection control of expiratory valve of the ventilator. So it's viral filter on the expiratory end and HMA filter on the patient end between catheter mount and Y piece. So next question is, best ventilator for ICU. You answer, sir.
One that fits your budget, one that has the company that gives you good service and good backup, and which sort of the staff in your ICU are comfortable with handling. I think that would be the bottom line. So don't buy a ventilator just like you buy on Amazon. That look at the picture and read some specification and buy it. Have them give you a demo. See that you are comfortable with it. Your staff is comfortable with it. They will promise you the earth when they want to sell you a machine, but make sure, ask others what sort of service backup they give you, what sort of parts, how expensive the parts are. Sometimes the consumables are expensive, or they get over, like flow sensors or something. They get you need to replace them very often. So the ventilator may be cheap sometimes, but those sensors need to be replaced quite often. Just go into all those sorts of things before you make any decision.
So as sir has rightly said, ventilator, there are so many good options, but man behind the machine is important. So whatever machine your staff is familiar with, they should know what they are operating. So that is more important than which kind of ventilator. Role of humidifiers.
So the standard humidification that we use is the HME filter, which is a sort of passive humidifier. The heat and moisture from the expired breath of the patient is trapped in the membrane of the filter, and that is added to the next breath, and which is good enough for most sort of situations, and it sort of covers the humidification for most situations. Sometimes where you've got thick tenacious secretions, you might want to do what we call as active humidification, in which case you put a humidifier in the circuit, and that's a heated humidifier, right? So it's a heated, so it has to be, and you, similar to what you put in your HFNC machine, you get these heated humidifiers. So they're actively heated. When you have a heated humidifier, please don't put a HME in the circuit, because then that will get blocked. You need to take it out.
Yes.
You also have to watch out sometimes that that the heat is transferred. You've got a wire or something which continues to heat the gas as it flows all the way up to the patient. It's delivered to the patient. Otherwise, you get a lot of water condensation in your circuit. So you need to take care of that. So you have to be also careful in how the water in the humidifiers change and how it is handled, because they have been known to be sources of infection, and you can carry infection into the patient. So you need to be careful when you handle those. So by and large, most of the times we make do with HMEs, HMEFs. Sometimes when you have got thick tenacious secretions, you do put an active humidifier, in which case, you just have to take the usual precautions and go ahead.
Any further questions?
Okay, I think we'll wind up.
Yes.
Okay, thank you to Vitrak for two very good presentations. I enjoyed especially the one on history, and I think you made everyone very curious and they want to know everything about ventilation in the first lecture itself. So I think we'll have to wait till you finish the entire series on this program. Okay, so thank you all for joining, and thank you, Vitrak, for your excellent preparation and precise delivery of your topic.
Thank you, sir. Thanks a lot for your guidance, and thanks ISCCM. Very nice initiative of this ventilator fellowship. So many small fine refinement in our understanding would be evolved. Even as a speaker also, I learned so many things from the history which I was not aware of. So it's nice to know this all detailed history of our ventilators. Okay, so we can conclude with this.
Good night. Thank you.